Oh, let's talk about pediatric medication administration and pain management. I believe we have 13 slides. This should be one of the shorter lectures for you, and hopefully it will be just as fascinating as all the other ones. Here's the student learning objectives for this 13 slide PowerPoint. The importance of knowing how to convert ounces into pounds, pounds into kilograms is essential. I guarantee that on every exam you will see a math medication problem, if not many. You will also see weights put into a variety of forms. It might be pounds and ounces. It might be strictly pounds. It might be kilograms, but you're going to need to be able to convert all of these from ounces to pounds to kilograms and back again. Because when I walk into a clinic in the United States, I might ask a mom how much a baby weighs, and she might say 6 pounds, 6 ounces. And I'm going to need to know how to put that into kilograms in order to give proper medication. So this is a ding, ding, ding. Make sure you pay attention to it for testing purposes. Other learning objectives is understanding how to safely give medications, creating a nursing plan of care for before, during, and after administering medications, appropriate techniques that you need to consider when giving medications, and applying concepts of growth and development, meaning how are we going to give it? How are we going to make the children and the families buy in to taking that medication when it tastes horrible or nasty? And of course, when we're giving shots and vaccinations and things like that as well. Also, understanding and being able to assess pediatric pain scales and discussing appropriate pharmacological and non-pharmacological management techniques for managing pain in pediatric clients. Medication safety. This should be nursing 101 for you guys. You guys are all so close to graduating. You should understand your patient's 6 rights. Maybe there's 7 now. I know personally that there can be 8 if you want to take it that far. So make sure you understand your patient rights, how to use them. Always make sure that you understand your patient's weight. Make sure that it's written down somewhere on your report sheet and that you know how to do that conversion factor again. Pediatric medication is all weight-based. That's why it's so important to have that kilogram. Your conversion rate is right there. 2.2 pounds goes into 1 kilogram. And if you need the conversion for ounces to pound, it's 16 ounces to 1 pound. You also need to understand that because kids are smaller, they have different distributions and metabolic rates of different medications, right? We're not going to give an infant under the age of 6 months Motrin because their kidneys are too immature to metabolize it, and we will cause kidney problems. We want to make sure that we give penicillins very slowly, especially gentamicin, because it can be toxic to the ears. So if we give that too fast, faster than their bodies can metabolize and distribute it, we can actually cause deafness because of it, right? Livers don't mature the second babies are born. A lot of times we need to give that child a little bit more time to grow. So while we can give Tylenol much earlier than Motrin, right? It is metabolized by the liver, so we want to make sure that we're not giving them Tylenol like you or I might take it every 4 hours. Maybe we only want to give it every 6 hours to give that liver time to properly metabolize it and get it out of the system. All right. When it comes to what we ask when it comes to medications, right? This is going back to your rights. Do we have the right patient, the right medication, the right time, the right dose? And we want to go ahead and make sure that we're checking orders. We want to make sure that there's no new orders that have come through. Maybe we had a lab draw for a gentamicin peak or trough, because this is a medication that we have to keep in a therapeutic range, right? If that medication came back and a doctor saw it, or that lab value came back and a doctor saw it, they might have changed the medication order. So we always want to check the latest and greatest orders, make sure that we are administering medications to those newest orders. We want to make sure that we have an accurate list of the current medications, nothing new is snuck up there. We want to make sure parents understand the signs and symptoms of allergies, right? I'm going to tell you, my daughter, who's 22, has been on amoxicillin and Augmentin many times in her life. Lily is 22. She had lots of ear infections when she was growing up, and she was just diagnosed with pneumonia over the winter break, and they gave her Augmentin, and she woke up the next morning, head to toe hives, difficulty breathing. She was in full-out anaphylaxis. What saved her was when they gave her her first dose of Augmentin, she also took a steroid to go with it, and that is what kind of protected her. But now, moving forward, she won't be receiving any penicillin. So you never know when that anaphylaxis might kick in from any medication exposures. And you can't just assume that because a child has taken this medication before that everything's going to go well again. You always want to make sure that you're looking and reassessing the things that we have done and given, right? We want to make sure that we have the most current weight, because all of these doses are based on their weight. If you have a child who hasn't been weighed in a month and you're trying to give them a seizure medication and they had a growth spurt, you are not going to give them enough medication to stop that seizure. So you always want to make sure that you're giving it to the most accurate weight. Then you want to ask the parents. You want to talk to them and say, how do they normally take medications? Are they able to swallow pills? My sister, who is much older than me, and I know I'm old, so she's even older, still to this day cannot swallow a pill, right? I asked a child one time how they took their medication, and it was I think she was 4 years old, and she asked me for a cracker, and I said, "You want a cracker to swallow a pill?" And she said yes, and the mom said yes, that's the only way she can swallow pills. And the child chewed the cracker up, and right before she swallowed it down, she popped the pill in and she swallowed it with the cracker. That was a new one for me. I thought I had seen it all, but that was all new, right? Maybe we need to crush pill, put it in applesauce. Maybe we need to flavor the Tylenol more than it's flavored. Maybe it needs to be a ready dissolved tablet. Maybe it needs to be a liquid instead of the pill. There's a lot of different ways that we can do it. We also need to make sure that we understand, right, how the medication needs to be given. Vancomycin is not going to be given in a pill form. That's going to have to be an IV. Maybe we need to change it to a different antibiotic, and we can do an IM of clindamycin, right, to help the cellulitis. We need to understand that what we're doing is and what we're giving is to the best care plan of the patient and most acceptable for the developmental stage. So once you are there, you have the order, you've made sure you have all your rights, you've made sure that you have the most current order, you are still going to go ahead and make sure that that dose looks appropriate to your patient's weight. So what does the order say? Is my concentration correct? Make sure that you're always double checking the safe doses and calculating it out. Remember that pharmacists and people that work in the pharmacy are human too, and anybody at any time can make the mistake that can cause detrimental effects to that patient. So be the person, take the extra step, make sure you're protecting your patient, be the best advocate you can be. The habits that you start forming now are the ones that are going to stick with you But as you start adding shortcuts throughout your profession, those are what allow errors to be made. So try and find good habits to set and stick to them, like calculating, is this a safe dose for this patient? Look in the med handbook, pull it up on your pharmacy. Does it look like it's an appropriate dose? Have you given amoxicillin before and this seems like doubling down? Maybe you need to question it. It's okay. I ask a lot of questions from a lot of people. I ask from the pharmacy, I ask from neonatology. I will challenge doctors, and I will start off respectfully saying, I'm not challenging you, I'm just trying to understand, why are you giving this massive dose of vancomycin instead of breaking it up into like every 12 hours? What makes this patient different than all the other ones that you give? Because maybe they were distracted, maybe an error was made. You never know. Or maybe you're going to learn something new. If you ask questions respectfully in advocacy for your patients, it's really amazing what you can learn. So when we're administering oral medications, we want to talk to the parents about how do you give the meds, right? What's the best way? Do they take it with a syringe? Do they take it like better with a nipple? Do you need some orange juice? Do you need some magic chocolate milk? Do we need to flavor, right? We talked about some of these things. We also want to talk to parents about things not to do, right? We do not want to have them using teaspoons and tablespoons from their silverware drawer. We want them to use standardized devices to measure, right? A measuring cup or a measuring spoon from the pharmacy. These are the things that we want them to use. We want to talk to them about not mixing an entire dose of medicine in a whole bottle. Because if the baby doesn't finish the bottle, then how are we going to know how much medication they actually received? Instead, maybe just give it in 5 or 10 cc's in the beginning of a bottle to make sure that they drink it all down when they're the hungriest and they don't care what the medicine tastes like. And then they can have the rest of the bottle after they finish the medication. Or maybe we're going to just squirt the medicine into the gastric tube or the G tube at the beginning of their feeding, not putting it into their entire enteral feeding, because if they vomit at the end of the feeding, they're going to vomit up the medicine. And again, we won't know how much retained and how much we lost. So other administration methods, right, is the ear. Again, it's very important to understand which way to pull that ear for which age group, and 3 and younger is down and back. You need to know that, right? We want to make sure that our eardrops are warmed up. You want to massage them into the ear with rectal. Just insert it right past the sphincter and then hold the buttocks together. It's a little bit easier when you have your littler patients, your little babies that don't squirm so much. With your masks, when you try and do albuterol treatments with toddlers, it doesn't go over well. For whatever reason, when you go to put that mask on their face, it gets them like set off into tantrums. They become an octopus with 8 arms, right? So maybe you have to have the parent hold it an inch or 2 from their face with the mist blowing on them, right? You are going to have to adjust the way that you give medications based on the developmental stage of these kids. That's why development and play is so important to understand. Injections, right? You have IM, sub-Q, and intradermal. That's what the ID is, right? And there's a lot of positioning techniques that we're going to be talking about that will help you get some of these things done. When you talk about putting in eye drops, any patient at any age, the best way to give that is to have the patient lay on the floor or tip their head all the way back. So it is, they're staring directly up at the ceiling. And then you put 1 drop at the inner corner of each eye. And when they open their eyes, that drop will gently fall in. I am going to tell you that when you tell a child that eye drops do not hurt and you are putting eye drops in for pink eye, if this is the first 2 days of pink eye and those drops, you will be lying to them. When you put drops in 2 eyes for pink eye the first 48 hours, it burns. The only thing that you can tell the patient is it might burn a little bit, but every time we put the drops in, it will get better and better and better. If you tell them it's not going to hurt with pink eye, it does, because that antibiotic is killing the cells, that cellular bacteria that is in the eyes, and it's also going after all those bacterial waste products, right? And it's all over in the eye, so it does cause the stinging pain. So don't lie to them. It's better to be honest. Try and provide atraumatic care. Maybe give them a little ice pack or a little warm washcloth to hold on their eyes to help with the stinging. Tell them to blink a lot, right? But the important part is that you're honest and you try and make this as less traumatic as possible. So here's some techniques on injections, right? You have your intradermal. So this might be your TB test or a medication that needs to go just under the initial layers of the skin. You can see how we're giving that, and that I believe is like a 90 degree. Oh, no. This is a 90 degree angle, sorry. Down here where we're giving the intramuscular going straight up. The 45 degree angle is smaller in young children with less subcutaneous tissue. And then I think that's a 15 degree angle for that intradermal injection, I think is what it is. Sorry about that. Didn't mean to confuse you at all. So again, 90 degree for your subcutaneous, or 45 for your smaller subcutaneous, and then about 15 for your intradermal. I'm not really going to sit here and ask you about degree angles for injections. It's more important that you know how to give them. And then, of course, for an intramuscular, we're always going to go for the thighs, even like up to young school age. Once they hit about 6, then most of the time they have enough muscle on their upper arms that we can start giving vaccinations in the upper arms and the deltoid, right? But usually our preschoolers, toddlers, and infants, we're going to do for that middle third of the outer aspect of the thigh, as they're showing there with that baby's leg. So what to consider when we're talking about pain? We want to understand the age and developmental group, right? Is this a child who is school age and can reason, or is it a preschooler that has that concrete thinking where you can tell them it's only going to hurt for a minute, distract them with picking out a Band-Aid? Yeah, they're still going to cry when you give them the shot, but it's usually very short-lived, right? You need to talk about culture. You need to think about it. Ask the parents, how do they handle the pain? Have they had pain before? Do they tolerate it well? My daughter Abby, who is 20, has a very, very low pain threshold. When she was a child, you could walk by her and just gently bump her and she would fall on the floor and cry. To this day, if you break out a needle, she will almost pass out, just knowing that it's going to cause her pain. She has a true fear of it. Lily, on the other hand, my middle child, right, got her hand slammed in a car door when she was 4 and barely cried. She was really holding it back. You could see some like little trickles of tears. But I looked at her and I'm like, Lily, does it hurt? And she's like, just a little. And I expected her whole hand to be crushed. And it was fine. She shook it off and she moved around and she was fine 5 seconds later. So everybody has different pain tolerances. So you really need to include the family in these discussions about pain and what is distracting to those kids. What brings comfort to these children? What is an acceptable pain? If they are having migraines and they're being hospitalized for the migraine, and they say that their pain is a 9 out of 10. Okay, let's get them medication. Let's bring them comfort. Let's dim the lights. Let's take away some of their screens. If they're there for a migraine and they tell you that the pain is a 5 out of 5, okay, maybe we need to just take away the screens and dim the lights and tell them to lay quietly. Why don't you rest? And if it creeps up to an 8, then we'll go to the next level of medication, right? Have that pain plan that the parents are part of that can help you with the distractions and understanding what is tolerable to them and what is not. And making sure that they all understand that zero pain is usually not realistic for a pain expectation. We're never going to be able to take all the pain away, but we can use different techniques to keep it acceptable, down to a mild annoyance, right? Maybe to a 2, maybe to a 3. So with pain scales, we tend to use the FACES and the FLAC and the 0 to 10. So if they're school age, some even preschoolers can use the 0 to 10. You just ask them, like 10 being the absolute worst pain you've ever felt and 0 being nothing at all. Where does it lie? A lot of kids really respond well to the FACES pain scale, the Wong-Baker FACES, because it allows them to understand the emotional component to it and relate where they feel, right? So they're going to show you the face that they feel. And that one is very, very helpful. The FLAC scale, we're going to use for our babies. We're going to use for our nonverbal patients. So if you have a cerebral palsy child who's bedridden, I'm going to report a FLAC scale if they are not able to help me understand what their pain is. So make sure that you're picking out those appropriate scales. Here on this slide it says the FLAC is appropriate for 2 months to 7 years, and FACES is 3 years of age and greater. Again, remember in the pediatric world, we will revert to that FLAC score for any nonverbal patients that we have. One of the things that we try and do in peds is try and provide safe areas and non-safe areas. So if you have a chronic child who's admitted to the hospital, some of our liver patients, our transplant patients were in the hospital for 3 months, 6 months, right? We need to let them know that that room that they sleep in is a safe place. Otherwise, they're never going to sleep if they think everybody that walks in that door is going to cause them pain. So one of the things we try and do is we try and use treatment rooms, such as the one you see here. It's a specialized room that tends to have lots of distraction, toys, devices, murals, lots of things to make some of the painful procedures that we do, like lumbar punctures or IVs or wound cleaning, a little bit more tolerable. So we tell I might walk into a room and tell the patient and their family, we're going to do wound cleaning after breakfast. So as soon as you're done, we're going to go into the treatment room and we're going to clean the wounds, and then we'll bring you back. By doing that, you're creating the safe space that the patient and family can thrive and try and keep their routine, have safe sleep, right? Have that safe space, and then they know that anything bad would be in the therapy room. It does help, and it helps to provide a little bit less traumatic care. We tend to use more child life therapists and play therapies in there. We try and do a lot more distraction. I'm not saying every hospital has these, but all of your dedicated children hospitals will have them. And also, you will find that nurses are very big on including families in distractions, right? They'll ask parents like, oh, do you have Baby Shark? Is that something your child likes to watch? What's their favorite video? I'm going to start an IV. Can we get their favorite video out to try and distract them? And then we get the parents to help hold so the children feel comfortable. We do a lot of things to really make the kids feel safe and understand that everything that we're doing is to make them feel better. It's short-lived, and we try and always have positive outcomes. Pharmacological and pain management. So when we talk about pain, we want to make sure that parents understand that it's best if we give scheduled meds when they're scheduled. So if we have Tylenol written for every 6 hours because we're trying to get the child off the morphine, then it's best to explain to the parents, right? We're trying to keep that pain from going up and spiking, but keeping it at a nice constant pace, which is more tolerable. When we start IVs, we might try and use localized medications, such as lidocaine or lidocaine sprays. That really helps us to kind of get through that little pinch that seems so uncomfortable for the kids. We want to really avoid IM pain medication for pain management because, again, it's more of that here's your bolus, right? And it takes more time to absorb, so it's a slower acting as opposed to IV or oral. So it's really, and it kind of, because it sneaks up, it takes a long time to get distributed through your body. You never know if it's running into like the next dose, if it's going to affect anything. So it's not as easily controlled. We try and do a two-step approach. We're always going to try and do that Tylenol and Motrin baseline, try and hit them regularly and around the clock with that, and then have something written for breakthrough pain, such as morphine or maybe a little Toradol, something like that. You might even see in some of your tertiary centers, such as Glories in Christ, that when they do the pumps, like a morphine pump, a PCA, that they're going to run some Narcan, a very low dose Narcan. And they've actually found through research that Narcan, given at very low doses in a drip, provides boosted pain relief, even though it kind of goes against everything that we know about Narcan and opioids. But I'm happy to have a discussion with that at any other time because you don't need to know that for the test, but just some information for you. Okay, and rounding out the pain discussion, right, here's our non-pharmacological pain management. And this is, again, the distraction, the guided imagery. Guided imagery is something like guided meditation. You're walking through a forest. You see ahead of the forest a break in the trees. You see that it's opening up to a beautiful field. You start walking faster to get to the open field. As you get into the field, right, blah, blah, blah. That's an example of guided imagery. You're playing out of story, something to pull the child's mind into so they're going through a painful procedure. With small kids, we might try and use, right, our infants, we might try and use swaddling or kangaroo care, skin to skin for those neonates. And maybe I can start an IV with the mom does the skin to skin. It's gonna, skin to skin actually helps boost the endorphins, which decreases the pain. Infants also do a lot of non-nutritive sucking. It's very comforting to them. And if we can give them a pacifier dipped in a little sugar water, that's what you're seeing here on this slide, right? That kind of lights up those dopamine receptors in the same way, even though it's just sugar water. And that really helps with the pain as opposed to just giving morphine. When they're older, they're toddlers, we can give them stickers or special Band-Aids or little tokens for rewards. Yes, it is bribery. Yes, it does work. And many parents are not opposed when we get to some of those painful procedures. Again, if it's going to hurt, say it's going to hurt, but talk to them. Say, relate it to something. It's going to pinch just a little bit, or it's going to be super fast, or it might linger, but every second you breathe, it's going to get better, right? The more honest you are, the more they will trust you, and the more smoothly the procedures go. I hope that you enjoyed the pain and medication discussion. Please let me know if you have any questions. Email me, text me, call me, bring them up in class. We will talk more about this. This is just some of that basic information for you.